Hi, everyone. I want to welcome you to the webinar for On the Frontlines, Nursing Leadership in Pandemics. I'm Victoria Rosner, Dean of Academic Affairs at Columbia School of General Studies and a professor in the Department of English. We are very excited to be presenting this project as a part of Reunion 2021 to the Columbia alumni community, of which I should mention I am also a member. I really want to thank Aviva Zablocki and Jawad Cipriani from Columbia GS for making today's event possible. I look forward to spending the next hour not only talking about the worldwide role of nurses in combating pandemics, but also giving you, as alumni, some insight into the kinds of research collaborations that happen at Columbia. So let me tell you a little bit to get us started about the history of our work. The project that we call On the Frontlines began about 3 years ago when COVID still lay in the future. The members of this group, some of whom you're going to hear from today, came together around a shared conviction that the role of nurses in past pandemic outbreaks was absolutely crucial and yet poorly understood or valued, omitted from the historical record and neglected by policymakers charged with planning and resource allocation. Our group received startup funding from the Columbia Center for the Study of Social Difference, an interdisciplinary research center that fosters ethical and progressive social change and supports faculty groups like ours. So our initial focus back in 2019 was on the Ebola outbreak in West Africa. As you may know, nurses were absolutely critical in that largely successful effort to contain Ebola. This was between 2014 and 2016. And those nurses succeeded against daunting odds that included an overall case mortality rate of 40%, supply shortages, and the lack at that point of either effective therapies or a vaccine. Members of our group traveled to Sierra Leone and Liberia in the summer of 2019 to conduct oral history interviews with nurses who worked on the front lines fighting Ebola and to learn more about their work. Their stories were powerful and significant, and we have recently published them on our project website, which you will be hearing about shortly. When the COVID-19 outbreak began in 2020, it was clear to us that we needed to expand our work, both to document the role of nurses in fighting COVID and to turn the lessons learned by the Ebola nurses to good account. You'll hear today about both these efforts. We're going to get things started by giving you a chance to actually listen to the Ebola nurses we interviewed and see how we've captured their experience and expertise on our website. From the beginning of this project, I am pleased to say we have thought it crucial to have Columbia students involved, most notably students from the Columbia GS Post-Baccalaureate Pre-Medical Program and the Columbia School of Nursing. 2 post-bac pre-med students have led our student effort this year, Kurt Halyaba and Mina Shah, and I am delighted that they are both here with us today. We thought the best way to get things started would be to share with you some of the nurses' stories with which our work began. And to accomplish this, Kurt and Mina are going to give you a quick tour of our new project website. Before I turn things over to them, I have just 2 quick housekeeping notes. First, in the interest of time, I am not going to give full introductions for our speakers, but instead their bios will be posted in the chat for you to read. Second, we also very much want to leave time for your questions and for discussion. So please feel free to post those questions in the Q&A as we go along. So with all that as preface, I really want to welcome you again to this reunion event, and I will hand things over to Mina and Kurt, who will show you the website.
Thank you, Victoria. Hi, everybody, and thank you so much for coming today. My name is Kurt Halyaba, and I am a student. I just finished up the post-bac pre-health program at Columbia, and I joined this project in September of 2019 in my very first month of school here. At this point, Mina and I would like to walk you through our website. A lot of energy and effort has gone into this site over the past year with the help of over 100 student volunteers from both the School of General Studies and the School of Nursing at Columbia. We've built this website to properly showcase and honor the incredible nurses who fought during the Ebola epidemic. Additionally, we hope that this site will serve as an archive for future researchers to learn about the experiences of an often overlooked group in healthcare and through this oral history format. So without further ado, I'd like to begin by showing our homepage. As Mina is sharing, oh, hold on, I'll pin her screen so that we can all see. Here we go. So from the get-go on this homepage, we see we have the Ebola portion of the website, which we'll be showcasing today. Mina, if you can go in there. So we have three portions to our website here that we'd like to show, and we'll start with the timeline portion of our website, and we'll work to history and then to the oral histories themselves. So first, the timeline was built as an interactive platform to be able to ground our audience and explain the where, when, and how the timeline of the Ebola epidemic came about. This will give some context as to some of the stories and some of the key events that happened. So with this interactive format, you can click as Mina is going one by one to read the news stories, click on the sources, or you can also jump to any time period in the range from 2014 to 2016 to get an idea of when these key events took place. So the next portion of the website that we wanted to show was the history page. And this page is sort of like a mirror to the timeline page, but here is much more text heavy that explains out the key moments in the development of the epidemic. In this page, we highlight many of the different contexts of regional contexts, conflicts that arose during the eradication and the fight against Ebola. And we explore a lot of different topics, including gender roles, dangerous myths that arose during the pandemic or the epidemic. And so we hope that you'll be able to read through this document, which also provides more context for the stories that these nurses shared. And without further ado, the best part of our website here, I'm going to pass over to Mina to share.
Great, thanks so much, Kurt. So I'll showcase a couple of the oral histories. So we, during the project, project members interviewed 39 nurses and midwives in Liberia and Sierra Leone, and each of their profiles can be found on this page. If you hover over each nurse and midwife, you can see their name, and then you can also filter by each of the countries as well. So if you want to be specific about Sierra Leone or Liberia, you can filter the nurses and midwives that way as well. I'd like to highlight today two different nurses and midwives and just show you, give you a sense of what each page looks like once you go into their particular oral history, and then also give you a sense of what they sound like and what their stories sound like. So I'll start over here with Numu B. Charm. She's a nurse educator and nursing officer at a government hospital. And we'll go ahead and listen to a portion of her interview.
How do you think the community is still behaving in terms of sticking to some of the messages that we are taught?
It is really difficult. It is really difficult. At that time, the sensitization went on for station to station. You will see hand washing stations, but now people, because the outbreak is no more, they are now neglected. Some people are complying, but others are not. It is not.
So if you have to tell us some of the nurses from other countries who may not have experienced the Ebola or any epidemic, what message would you share about your leadership role in epidemic as a frontline worker?
I'll just tell that whenever there's an outbreak, as a nurse, if you have gone through training, you should not be afraid to be a leader, a role model, because what we are taught, I believe you put in practice, and you should have confidence. Then most of the nurses who are in front line is because they have little or no knowledge, and there was no confidence in working. They got themselves infected. But with my own experience that I have during the Ebola crisis, I know I will walk anywhere with any epidemic disease. I will not be afraid. I will be vigilant. Once I have been trained and I have knowledge, I will go and extend my knowledge and do my training that I was taught in practice, put them into practice. So I think
And I'll also
I'll be a
give you a little
champion.
bit of a sense of Mawa Kamara Verdier. She's a registered nurse and treasurer of the Liberian Nurses Association.
So, what do you think were some of the challenges that you experienced during that time?
Challenges, communication, and culture barrier that will really challenge us. And then religious belief. We had a real challenge in that era. Especially when government came up and made a public pronouncement that they were going to start cremating Ebola bodies.
Yes.
People became very stubborn. Even where they will know that the patient have all the signs and symptoms of Ebola, they will tell you, no, my patient is not going. I don't want you to burn my body.
These brief snippets, we're already hearing echoes even before the COVID pandemic started. We're hearing echoes of things that would have been so useful for us to have known had we just listened in terms of curbing this current pandemic we're experiencing. Before I hand it off, I'm just going to show us a couple other quick features of the website. Here at the bottom of each of the pages, you'll find links to our social media pages on Twitter, Facebook, and Instagram. And the Instagram in particular is really exciting. We've been doing spotlights on each of the nurses and midwives to highlight each of their own experiences. And then we also have this reflections page over here that you can navigate to. And this should give us a sense of it. Some of our team members have put together thoughts about, what this project really meant to them and how important it was in shaping the way that they'll think about outbreaks in the future. So that's also something that you can turn to as well. Thank you so much.
Thanks to Mina and Kurt. We've had probably, over the past 3 years, close to 100 students, I would say, involved in this project. And it's really been a great part of the work. So I hope you'll take time to return to the website after the event is over, but now we're going to hear from 3 of our project leaders, each giving a different perspective on the role of frontline nurses in pandemic outbreaks. And we're going to start with Jennifer Dohrn. Jennifer is herself a nurse and midwife, and she is also Assistant Dean of the Office of Global Initiatives at the Columbia University School of Nursing. Jennifer?
Thank you. Very honored to be here and to speak with all of you. This project really for me has been both a personal as well as a professional journey. And having spent many years, at least 12 years of my professional life working in South Africa and other sub-Saharan African countries on HIV pandemic and working side by side with nurses and midwives. So to get to have this experience to go to Liberia and Sierra Leone and meet many of the nurses who I've been in contact with but had not met in person to record their oral histories was amazing adventure. And here you see, this is actually a nurse in an Ebola treatment center holding a hand. And I love this picture because it shows what we always do in the midst of gloves and protective equipment. We are always reaching out for the human touch, for being there with people. And this past year, 2020, has been WHO's year of the nurse and midwife. And I'd like to just share a picture, a moment to honor the midwives and nurses who have been on front lines of pandemics. Here you will see nurses in Eastern Cape, South Africa in 2006. When you walk into the doors of the Liberia Nurses Council, you will see immediately pictures of all of the nurses who gave their lives during Ebola. Here are nurses in Wuhan, China during International Nurses Day last year. And here are nurses in New York getting ready for their shift. And I always begin my approach to talking about nursing is that for a robust response to pandemics, nursing is key to what works, what is essential, what is achievable. And it looks at managing infectious disease outbreaks as one of the greatest challenges of our time, which I think we're all aware of now, with heightened urgency in our increasingly interconnected world. And as nurses, we are often the largest cadre of health workforce, frequently the only available providers, and too often we bear the highest burden of death during outbreaks, pandemics, and global pandemics, epidemics and global pandemics. And we have lessons that we have learned which are not often shared and looked at. Our responsibilities were providers, educators, protectors, and advocates for the community we serve, gatherers of data, researchers, leaders in policy, Victoria explained a lot, as did Kurt and Mina, about our project, so I just want to go into some more description of the journey. So this is our team in 2019, when we had a delegation that traveled first to Sierra Leone and then to Liberia, and you will see us meeting here with the chief nursing and midwifery officers, and that they hold the highest position within ministries of health that represents the nursing and midwifery professions. And here we are with Mary Fula, and here in Liberia, we're with Tarlo Kimwonkpa. Our methodology in looking at this project was we recorded 39 nurses' stories in person. Here I am doing one of the interviews, and Josephine Findaselu was one of my heroes. I first knew about her from the New York Times in 2014. And going to actually get a needed recorder was an amazing journey for me. And also everyone who I teach in School of Nursing knows about Josephine as one of the heroes on the front lines. We took these interviews and then they were transcribed and analyzed to understand lessons learned and recommendations for policy change. And part of what is also on our website to be filled out we expanded this project. Who would know when we started this that COVID-19 was going to be a major pandemic across the world. So we expanded it to New York City, and you can see the difference. Here I am recording nursing interviews. We recorded Mary Marshall Clark, who's speaking in a moment, who's also part of this group, recorded nurses' stories in New York City of what they learned. And they're still being analyzed, but I am going to put general observations of what we learned from them. So if you look at the two disparate regions of the world, global North, global South countries, there's an amazing similarity in what nurses experienced. So some summaries about public health outcomes from the oral histories that we learned. One is criticalness of knowledge about and access to infection prevention control measures. Essential, right, to have us health workers protected. One person said, when we had this outbreak, I bought the PPE. I bought with my own money. I have my children. I have to go home and meet my family. I don't want to infect my family. So I decided to buy these things. And very much important to learn what was necessary and how to protect ourselves. And in New York City, very brief, as I said, looking at the interviews in New York City, same reactions from nurses. There was a lack of pandemic preparedness, both educationally and clinically, feelings of frustration at our competencies, how we could perform. And certainly there were, in the beginning, there were reported changing protocols for PPE constantly. And this was very frustrating to know what was acceptable to protect ourselves and to protect other healthcare workers, and certainly the patients that we were working with. And nurses here feared a shortage of PPE. Another major theme was teamwork was redefined and changed for effective team response. In Sierra Leone and Liberia, nurses reported working closer as a team with doctors, with daily urgency loosing long-established hierarchical order of doctors over nurses. So one example were the stories of the nurses we interviewed of their entering Ebola treatment units. Everyone's life depended on performing as a clear unit, and they're gowning together, they're praying together, they're entering together, they're leaving the Ebola treatment unit together, We're all part of working in a different way, respectfully, to give full care. In New York City, there was also amazing closeness of working amongst all of the orders of the healthcare team. There was often no time for written orders, so everyone worked at their highest level of education training with no compromise of care. And now you see that the pandemic is lessening it, going back to much more hierarchical approach between doctors and nurses. And certainly there is a piece, which I mentioned, Victoria, you mentioned, about the majority of nurses being women and the role of gender in this. Another observation was nurses gave vital information, education, and care to their communities. This is particularly striking in Sierra Leone and Liberia, where nurses are the first seen in the community. We are engaged with the community. At the beginning, they said that they were at first fearful, the community where they lived, about the nurses because they were in these Ebola treatment units. And then once they did more education, explained how it was transmitted and how they could prevent it, there were marches through the streets where they were greeted by the community with, here come the Ebola nurses, and they became the visible heroes, which explained to the community what was needed and engaged the community, very essential. They were critical in translating and implementing safe burial practices and in providing health care services. So we can't have containment without providing healthcare services. New York City, there's a different role, though during the time of the heaviest moments of the pandemic, nurses found themselves called upon as experts from their communities to provide information. Our healthcare system gives minimal attention to public health and engagement of the community. So this was definitely something we learned differently from the nurses in Sierra Leone and Liberia. Nurses in both regions witnessed great suffering and death amongst their colleagues, their families, their communities, resulting in mental and emotional distress. And when we did the interviews, which are now 7 years ago, almost 7 years ago in Liberia and Sierra Leone, but 5 years ago when we did the interviews, it was as if they were speaking that this happened yesterday. The trauma, the pain, the grief was still raw. It had not been taken care of as part of a healthcare system in protecting nurses and midwives. Many said they had not healed. And this is a picture of Nurse Fonte Buogo, who immediately showed me a picture of his wife, who was a midwife. He lost his wife and he lost 4 of his 5 children, his in-laws, and was in terrible grief. New York City, nurses said they had no preparation for the volume of death and suffering that they witnessed. Most did not know how to do post-mortem care. It's not a routine function of nurses. They learned it quickly because during a shift they were doing sometimes 6 to 8 care on bodies, colleagues, and patients who had died. One nurse practitioner said to me, my eyes are always going to be looking for them. That haunting sense that has not been treated with gentleness and healing. Nurses expressed dissatisfaction with the lack of knowledge for their service and sacrifices. This was everywhere, both fiscally, publicly, and individually. Nurses, when asked, well, why are you doing this, would always say, because I took an oath. I took the nursing profession oath that I would serve my people. Nurses in New York City at first felt very celebrated, going out through 7 p.m. Pot banging. When I left my shift and walked outside the hospital, I was greeted with a moment, hero, one said to, and they could see quickly as this pandemic level, the surge decreased and sought after immediately afterwards. Nurses across Sierra Leone and New York City expressed wanting more involvement in policy guidelines for pandemic response, that they had lessons learned, that they knew what needed to be done, and wanted to be part of it, and most doors were closed. There was also in New York City a deep connection. Today is the first anniversary of the murder of George Floyd. I want to acknowledge that. It's a very important, horrendous time that continues in this country. And certainly the pandemic here in New York City, nurses were involved with both protesting racial injustice as well as fighting the pandemic. So results, some beginning results, nurses who provided care in both pandemics stated they persevered in spite of the many deaths. Disparate access to resources, spoke of inadequate recognition for their sacrifices, missed opportunities for intervention and providing community awareness of the pandemic, and consensus that infection control essential as a routine part of nursing education. And there are many potential recommendations for policy guidelines that we can look at, which would involve really putting the nursing cadre with a defined role at the top levels to disseminate knowledge about infection control, to redesign healthcare teams with their responsibilities for more inclusive and flexible roles, to designate the nursing cadre in countries as a linked community for engagement, right? Put us in this position because we have the knowledge. Providing well-being services, physical, mental, emotional, to all cadres of the healthcare team during pandemics and afterwards, recognizing our contributions and including us at top levels in policy development and guidelines. There's an amazing mural right outside New York Presbyterian Hospital, which is across from the new School of Nursing building that always strikes me when I walk to work every day, which is a thank you to nurses and to healthcare workers. So, thank you.
Jennifer, thank you so much for sharing that incredible account of helping us to think about Ebola and COVID and the connections between them. As you all are hearing, oral history has been the key methodology for this project, and just the commitment to having nurses tell their own stories in their own words. And to hear more about this, I want to turn things over to our next speaker, who has really directed the oral history aspect of the project that is so central. So let me introduce Mary Marshall Clark, Director of the Columbia Center for Oral History Research.
Thank you so much. And I'm so delighted to be with you today. I wish I could see you because as an oral historian, it's hard for me to speak without knowing who's listening. And I'm always so eager to connect, but I'll do my best. I just want to talk a little bit about oral history itself, because there are many kinds of interviews. There's a great journalism school at Columbia. The Center for Oral History Research has been here since 1948. And journalism and oral history, work together, teach together, but there are many differences. So oral history, try to imagine the safest place you've ever been, sitting on a front porch or a back porch or taking a walk, and just sharing your deepest feelings, reflections, worries, fears, momentous events with someone you really trust. That's what we aim for in oral history. The reason we were able to get the great stories we were able to get in West Africa were because the women who did the interviews were themselves nurses. They shared an identity with the people that they were listening to. This gives them both explicit knowledge and implicit knowledge. And oral history is both explicit and implicit. It is both an art and a science. The science side of it is we're studying one of the most horrific pandemics of our age. The art part of it is that we're listening to stories of human distress. We're in the position of being what I would call a co-witness to the catastrophe. We can't listen as uninvolved people. If we do, we're being unethical. What do I mean by that? In oral history witnessing, we think of taking on both the emotional and the intellectual state of the person that we're listening to. If we're speaking to a scientist, we want to understand everything that scientist has learned. We are speaking to a scientist who's lived through COVID, as I did recently. We want to know what the human experience of having COVID or Ebola in his body was. And somehow in this tension between the concrete, the scientific, and the ephemeral, the emotional, the empathic connection, we're able to document stories that Herodotus and Homer would have been jealous of. These are long histories. And I mentioned Herodotus and Homer because the irony is, for many years, the Oral History Research Office was at the top of Butler Library underneath the names of Herodotus and Homer. There are many other origins of oral history in the world. But we humbly listen in order to almost take on the identity of the other person who's talking about that suffering. In an interview I did with a nurse and a professional educator at one of the most crucially impacted hospitals in New York, she took me back to the AIDS epidemic in Philadelphia and New York in the 1980s to be able to explain the horrors of this pandemic. That's what oral history work is, making historical connections. Just as our collections on the first 80 physicians who treated AIDS in the United States became a best-selling book, AIDS Doctors, Voices from the Epidemic. There will be many books, many poems, many songs, and many scientific papers written based on the interviews we've collected for this project. So I invite you, both with the Ebola stories we have up now and with the COVID-19 stories we will have up soon, to also become a co-witness, to let yourself listen and watch, perhaps when the lights are off, perhaps when you're feeling haunted by all of this and you want to be guided through this horrible tragedy with real knowledge. Put your feet up, take a walk with your iPod, go by the river, do what you do that makes you feel calm and let yourself learn. Just as one final thing, I want to express my gratitude for this group, Frontlines. I'm part of another group also documenting COVID-19. In fact, the interviews we're donating to you come from that group, which is the New York City COVID-19 Oral History Narrative and Memory Archive, located at the Center for Oral History at Columbia. We will make these interviews of nurses and providers available to you alongside interviews with low-paid, low-income workers, food delivery people, other health providers, and teachers and students. And so this archive will stand as a holistic effort to capture the people that the COVID-19 pandemic has impacted to the greatest extent. And then you will be able to draw connections between what is happening in New York and what happened in West Africa. You will scratch your head as you're writing your scientific paper for the person who said, how can we prevent the next one? Why didn't we learn from Ebola? Why did the global health community take that project up and then dump it? What can we do now to learn about the next pandemic? For one thing, listen to these stories. Thank you.
Mary Marshall, thank you so much for those powerful remarks. And I hope that people who are listening today are beginning to see the way that these different forms of scholarship and are coming together in this project, so that the perspective of the healthcare professional and the provision of medical care in a pandemic with the historians, and now crucially, the third leg of the tripod that everything stands on, you'll hear about, is to enact what has always been a major goal of our work, to put nursing leadership in pandemics, the role of nurses, the stories of nurses on the agenda of policymakers, so that we can be in a position of prevention. To talk about this effort, I'm next going to introduce Wilmot James, who's a senior research scholar at Columbia's Institute for Social and Economic Research and Policy, and turn things over to Wilmot.
Thank you very much to Victoria. I hope you can see my screen. I'm happy to be part of the team talking through the issues related to the work we've been doing in the area of Ebola and COVID-19. And I just have 2 slides to share with you. So let me just repeat what my colleagues have been saying about what we learned from the Ebola experience, as well as the COVID-19 experience. We learned that when it comes to healthcare workers, that their salaries were often not paid or they were irregularly paid, that they received no to little support for their families, that they experienced a high level of stress on the front lines, including burnout, that sometimes they had to deal with impossible ethical dilemmas with no proper decision-making guidelines in place, that there was poor provision of infection control, prevention and control systems, including personal protective equipment, that there was very little political support at the highest levels, and very little management backup, and finally, that not enough of the learning that they perforce experienced was codified for next phase use when it comes to interventions. That's what we learned.
Wilmot, I'm sorry to interrupt you. We're seeing your whole desktop rather than your slides.
Oh, well.
Can you end the screen share and come back in so that there it is.
Okay.
Now we can see it. That's perfect. Thank you.
All right. Well, then I certainly shared too much information with you, but never mind. So let me say that this is a useful slide that gives an outline of the 5 interventions that Resolve to Save Lives, which is a global public health entity focusing on epidemic prevention. And it essentially identifies what we regard as important policy measures. These are more than policy measures, these are actual interventions that Resolve to Save Lives undertook together with governments so that the staff, in fact, is embedded in governments implementing these. So it's more than simply policy on paper. These are actual interventions. First, as you can see, the full implementation of infection prevention and control and WASH standards. Secondly, investing in training tools and resources, using and improving tools to monitor implementation, improving data collection and accountability, which is about metrics, and then increasing and mobilizing increased donor support for healthcare worker protection. So we go along with these interventions, given what we've learned about the Ebola experience and also more recently the COVID-19 experience. So what we want to do now is enter into a next phase of research to assess the capacity of countries to do those things. So my final slide is an outline of exactly what that is. Let me just say that there has been an ongoing study that I've led looking at pandemic response in Egypt, Ethiopia, Kenya, Nigeria, and South Africa. And for the next phase of our work, we'd like to use this as a baseline, together with other countries that we've had experience with as a baseline, for seeing the extent to which the policies to protect healthcare workers in the way that I've outlined in the previous slide, in fact, was enacted as a measure of their leadership, because we think that it's important to see this as part of what's required at the highest levels of leadership in individual countries. And these are the research questions we're going to ask, and we're going to put our team of researchers to work to answer those questions. Firstly, usually it's health ministers, but with pandemic response, it becomes presidents or prime ministers. Did they, in fact, make the protection of health workers a political priority? We will assess that. Secondly, were bespoke budgets set aside for that purpose? together with other pandemic response items, but was the money set aside to do that? Thirdly, were salaries paid and paid on time? Were support services provided and provided on time and in the right places? Fourth, was adequate infection prevention and control, including PPE, provided? And finally, was there proper management and conflict resolution services provided from the human resources point of view? Those are the key questions that we're going to put and subject that to a research project that will take probably a year to complete to start off with. So this ongoing study that I'm referring to is already funded by Smith Futures. The work I've outlined here is a component of that, and we are hopeful that our present funders will be able to finance that research looking ahead. And with that, thank you very much.
Wilma, thank you so much. And thank you to all of our speakers. I think, again, as our speakers continue to add their voices, you really hear how our project is focused on placing healthcare workers, their well-being, their security and safety at the center of really the world's gaze, both from a historical perspective to understand their experience, but also from a policy perspective and a governing perspective to ensure that our healthcare workers are valued and are ready and willing to continue to fight for all of us. I want to save time for your questions and discussion, and please feel free, as I said, to put questions in the Q&A. But before we open things up, I just want to say a few words about where we see this project as heading. As you've heard, the work of On the Frontlines has implications that resonate in multiple directions: healthcare, government, history, more. I want to just call attention to a further dimension of this story that I see as really critical, and that's part of why I became involved in On the Frontlines from the beginning, and that's gender. You've been hearing that nurses make up the largest proportion of the professional healthcare workforce worldwide. To understand, I think, why nurses' work has been understudied, you have to consider the implications of the fact that most nurses and midwives are women. Just to put some numbers behind that, 80% actually of nurses in most regions of the world are women. And although women comprise 70% of the global health workforce overall, they hold only 25% of health leadership roles. So these numbers tell a certain amount of the story, but the situation that they summarize, I think, is more complex. Many cultures think of women as natural caregivers. In this context, nurses can be looked upon not as professionals with the potential to lead and to drive policy and planning, but as women who instinctively provide care. One enormous consequence of the naturalization of women's work, which I think Wilmot's remarks gestures to, is that women are systematically underpaid. The World Economic Forum Global Gender Gap Report for 2018 estimates the world gender pay gap at 16%, but interestingly, the number is almost double that in the healthcare sector. The predominance of women in nursing can propagate the stereotype that all nurses are women and women are meant to be caregivers, not leaders. Of course, gender also intersects with race and class, compounding the readiness with which nurses' views can be set aside or not taken into account. The failure to incorporate nurses' knowledge is pervasive at all levels of healthcare workforce delivery from the top down. This is not an exaggeration. The World Health Organization itself had no role for nurses in its leadership team until 2017, when the WHO's very first Chief Nursing Officer, Elizabeth Ero, was named. President Biden did not appoint a nurse to his COVID-19 task force until a visible national petition effort pressured the administration to do so. They did go forward with that appointment. I'm pleased to point out that Biden's appointee, Jane Hopkins, is an immigrant from Sierra Leone. And finally, I just want to add from the perspective of our own project that when our student associates last year conducted a broad survey pre-COVID of international health policy guidelines, they found almost no mention of nurses. Again, kind of extraordinary in the context of nurses' prevalence and the centrality of their role in health care delivery. So if nurses, and I know this may seem obvious, but I think it bears saying, if nurses are not in leadership roles, then nurses are not being heard by policymakers. And the essential knowledge that nurses have, knowledge born of frontline experience in pandemic outbreaks, and you heard those voices in that experience today, does not find its way into policy guidelines and cannot guide our preparation for future, or I have to say, current outbreaks. When we began this project in 2018, as I've said, COVID-19 had not yet emerged as a threat. Of course, it was always a matter of when, unfortunately. As a result, we've shifted the scope and emphasis of our work, expanding our oral histories to include nurses who are on the front lines of the COVID outbreak in our own New York City. I am spending a significant part of my summer reading those remarks, preparing them for publication on the website. We're also working to use the insights we've learned from our interviews with the Ebola nurses to help combat vaccine hesitancy in Africa. Soon, we hope also, as Wilmot described, launching a new initiative to help establish international standards for the protection of healthcare workers. So that is our project. Thank you for listening. We are interested to hear your thoughts and questions. Thank you so much for attending today's event, listening to our work. Since this is reunion, I just have to close by saying how fortunate we feel that Columbia provides a home for projects like this one. And you can see how kind of unique to Columbia it is to bring together students and faculty from across the university to contribute to an effort of the greatest possible urgency to what Lee Bollinger has famously called the university's fourth purpose, which is to use the academic knowledge to advance human welfare. So we have 10 minutes left, pretty good actually, for questions. Start putting them in the Q&A, put them in the chat. One of our audience members shared a question in advance, and so I think I can get us started with that. Let me read the question. As we look ahead to the next pandemic, what would you ask for of emergency managers and community leaders at a state or local level, i.e., what can we do better? And I'm looking to our panelists to see who would like to get us started. Wilmot, do you want to start the conversation here?
Well, one of the things that's lacking is proper financing for pandemic preparedness. In our experience, when we studied the 5 countries in Africa, they really were forced to make things up as they went along and experimented and innovated and did all kinds of wonderful things. But the fact was that they had to cobble together budgets to deal with emergency response. So there were no emergency response systems in place. So there are 3 things you need to do. You need money to do it, so a bespoke budget. You need operational project management to be in place that combines all the services needed to respond to an emergency, and you need a proper governance structure. The usual norm is that if it's an accidental or natural event like COVID, the leading agency then is health, and the support services are given by defense and the police. And if it's a deliberate attack, a bioterror attack, the reverse applies. But you need a proper governance systems to do that, and a proper communication system with your frontline health workers.
Thanks, Jennifer. Go right ahead.
And adding to what you said, Wilmot, or going a slightly different way with it, I think we need a roadmap, and we need it now. They should be developed in place, because it's not when the next pandemic will happen, it will happen. It's what is defining now. So role from community engagement, managers, federal response, federal coordinated with local feeding back into federal. We did not have a response plan for any pandemics in this country. Secondly, I'm arguing invest in public health now. We have not built public health as in the foundation for our healthcare system in this country, which is the guideline in every country is always begin with community on up. And until we switch that, the funding goes back into the community level, community health centers, public health approach. We are leaving our populations disarmed and vulnerable. And certainly within the United States, that means great attention to structural racism throughout the healthcare system, which has to be dismantled and rebuilt. They sound big, but if we don't start them, do them now, we are going to keep repeating what we've learned now. And certainly my message is always, nurses have to be in from community to top levels, or you're missing the major cadre that could really impact both at national, global level and community level.
Thanks, Jennifer. Mary Marshall, you want to add something?
Well, just to add to those great remarks by both of you, I know that the health pioneer, global health pioneer, William Fege and others were asked by the National Academy of Sciences in August of last year. Helene Gill is head of Chicago Community Trust also, to write up a document to define what is an equitable healthcare vaccine distribution plan, to have national guidance. And they wrote the document because of Zoom. They went very fast. These are very brilliant people. They did a 300-page book in about 4 weeks. So that was taken up by the CDC as a framework, but gradually to distribute the vaccine all over the world, which means challenging patent laws, which means creating new systems for production, so that the Serum Institute in India, which is now failed for the moment, is not the only institute in the world that can distribute low-cost vaccines. So this document is a beautiful document available online, was gradually whittled away, it's being whittled away even now. So I think what we need is a health justice movement to go along with building a public health system, but real, documentarians working together with journalists and politicians and other people to make sure that there's a strong public campaign towards equitable distribution, manufacture and distribution of vaccines. I mean, Wilmot will know, but less than 2% in Africa have been vaccinated, less than 2 or 3% in India, which is just outrageous. This is a global pandemic, and until we're all well, we're all at risk.
May I have just a 2-second intervention? Is that you can have all of that. You can have a playbook, you can have financing, you can prepare this, but if you don't have leadership, we see what happens when there's a paralysis at the top. And for leadership, you require 2 qualities of a leader. The recognition that the problem you're looking at is in fact the problem. So you can't, so that's the first thing. And secondly, you need to mobilize systems that you've inherited. And if you didn't do that, you can have the best systems in the world for preparedness and nothing happens.
Thanks. Mary Marshall, you've turned the conversation a little bit to vaccines, and we have a question on that topic as well. You've brought up the issue of equity and access in vaccines, but the question we have is about another topic that is obviously everywhere in the headlines, and that is vaccine hesitancy, and how the insights perhaps of a project like ours can be turned to account in trying to address the challenges of vaccine hesitancy in the United States. So would anyone like to take a crack at that? Wilmot, you've unmuted.
Yeah, so look, the puzzle is, why would human beings not act in their own best self-interest when it comes to advancing health? And the answer to that question is a complex one. I think in terms of what we are facing is that the best way of maximizing vaccine take-up is to communicate direct, honest, evidence-based vaccine safety information to the public in a language that people understand. And so the communication of risk is something that is of the greatest importance. And to do that successfully, you need to have a trusted communicator. In our experience, that's your frontline nurses and midwives and healthcare workers and the broader medical fraternity and public health fraternity around that. Trusted communicators, but they do vary by country. We've seen that the army and the police have the most trust in Tunisia, for example. And in the case of South Africa, there's the least trust, right? So it depends. You need a clear message, and you need to be able to have a public that is willing to receive the clear messages in a way that they can actually digest and understand. Risk communication is key.
Jennifer?
Total agreement with you, Wilmot. What I would add is that I think there are different reasons that there's hesitancy amongst different populations, just like you said, into who are the trusted messengers and people who have systematically been cut out of healthcare, who have poor access, who've been experimented on, who have no trust in the healthcare system. That has to be rebuilt. And it gets rebuilt by investment in public funding, by leadership from those communities being engaged and having a voice. It's a process that has to be happening now and continue to happen post this. In this country, we have had measles outbreaks recently, and within the last 10 years, and the lagging, the ability to reject vaccines as life-saving when they kill these communicable diseases, kill millions and millions of people and children a year around the world, like measles, right? Polio. They're life-saving, and yet we have failed to really educate people in this country because they have not seen pandemics until this moment, or they've forgotten what people in the 50s went through around polio. Our amnesia, the WHO says our vaccine amnesia, how quickly we forget, unless there's constant reminders to people. So it's many levels that have to happen, and a blanket approach will not reach communities who have been feel no trust from the healthcare system. That's true in many places besides the United States, but certainly deeply embedded in here in racial injustice.
So if I may just make one small empirical observation. Countries and regions in the world that have had the most recent experience with vaccinations, which tend to be regions where the health burden is largely infectious diseases, have the least level of vaccine hesitancy. I'm sorry, it's badly phrased. But so in the case of Africa, the numbers are much better than the US. So Africa's performance in terms of vaccine hesitancy is much better than the United States, precisely for that reason. But just to add that as a point.
We're just about out of time, but there's another question hanging out there, and I love the spirit behind it. So I think we'll use this to close out. And I'm just going to read the question. It's really well phrased. How can physicians and people in leadership positions in healthcare better support and advocate for their nursing colleagues? How do we promote the more collaborative team approach and dismantle the healthcare hierarchy as described in the nurses' stories beyond life or death, pan or epidemic scenarios? What a great question. Jennifer, and then Mary Marshall.
Very short answer, since that's my life's work. One example is this project coming together and really seeing that nurses are heard. Everyone came into this. And I particularly want to note, Wilmot, your role in this, since when you and I talked before we got this initial grant about nurses and my experience and common experiences we shared in South Africa and other regions, other countries within the African continent, was really to make nurses' voices heard. And everything that ISERP continues to do has nurses engaged in. So make your checklist. Where do you have influence? And are you including nurses? We're there, we're ready, and we have expertise to participate at all levels. So it's changing the mindset too, as well as persistent struggles within medical healthcare professional organizations. So thank you for asking it, because it can only happen without just nurses. Needs a whole approach from healthcare advocates.
Thank you, Jennifer. Mary Marshall, you want to have the
Yeah,
last?
just wanted to thank you for the question. I mean, the question itself expresses the sensitivity that's needed. And some listening to some nurses' stories from various hospitals in New York. There were some doctors who didn't go into the ICUs except for a few moments, and the nurses were there all the time. And there were other doctors who tried to change that and who reached out to the nurses and said, you know, this is too much of a strain, let me take your shift. Those small acts of kindness were the key moments that kept these nurses going, who were doubly burdened with being the witnesses of the extreme suffering and death, being, you know, like priests and priestesses, you know, overseeing death and connecting people with their families. So the doctors who made the smallest gestures, I'm not answering on a systematic level, which I'm sure you're more interested in, but as on a human level, everything you do to change that helps.
I mean, the short answer, in my view, is that there has to be a process underway by which the power structures are altered. And that won't come easy, but that's what needs to happen. The way in which our institutions are organized do not, if you look at the incentive architecture, do not encourage cooperation. That includes universities. And so what's required, in fact, is to build platforms that make collaboration possible. Collaboration is essential when it comes to pandemic response. You can see what the collaboration was involved when you look at vaccine production across the private sector, public sector, and various divisions. And so what we must do is build collaborative platforms that provides incentives to collaborate. So it doesn't turn into such a heavy lift to do something that should be natural, that should naturally happen. So we have to learn to work differently. And this pandemic has illustrated the importance of collaboration and working differently. And we should not snap back into old habits when this is all over with. We should really take heed, learn from the lessons of cooperation and its benefits, and build it into a new way of working in the future.
I thank you, Wilmot. Thank you all. I think that last round of comments really gives everyone in this event today something with which to go forward on a personal level. And I love that. So let me just thank all of you for being here. Thank you to Mina and Kurt. Thank you, Jennifer. Thank you, Mary Marshall. Thank you, Wilmot, Aviva, and Jawad. Thank you all so much. And enjoy the rest of your reunion. Take good care, everyone. Bye for now.